and I will be inviting Dr. Parul Chawla Gupta to speak on basic steps of pediatric cataract surgery.
Thank you, sir. Good afternoon to everyone. Today I'll be presenting the surgical management of pediatric cataract, a video-based learning course, along with my co-instructors and chief instructor, Professor Jagatram. So the basic steps of pediatric cataract surgery for a novice pediatric surgeon. Congenital cataract has a worldwide prevalence of 4.24 per 10,000 people, with the largest prevalence in Asia. It is one of the most important treatable causes of childhood blindness. So for unilateral, we usually operate between 4 to 6 weeks of age, and for bilateral, 6 to 8 weeks of age. However, there are increased rates of post-operative glaucoma in the first 4 weeks of life. So starting with the surgical part, the superior clear corneal triplanar incision of 2.2 or 2.8 mm is preferred in children, as the wound is protected by the upper eyelid from trauma. Scleral incisions also can be given, and smaller, tighter fitting incisions help in better maintenance and stability of the anterior chamber. We should minimize the times in and out of the eye, and for the side ports, 2 uniplanar incisions are used. We should address small pupils in children. Small pupil is less than 4 mm. It leads to higher complications, as we all know. There can be small pupil due to posterior synechiae, as in uveitis, trauma, persistent fetal vasculature, or in cases of pupillary fibrosis. We should dilate the patient pre-op with tropicamide or cyclopentolate, or we can use intraoperatively 1 in 1 lakh adrenaline. We can also now use intracameral mydriatics like phenocaine, no financial disclosures, which is a combination of tropicamide, lignocaine, and phenylephrine hydrochloride. Why anterior capsular rhexis is difficult in children? Because it is thinner, elastic, it is convex shaped, it tears easily and runs in the periphery. AC is shallow in these eyes, IOP is lower, there is a poor red reflex due to opacities. Anterior capsular rhexis can be done by various means, like using a curvilinear capsulotomy, using a needle, using the vitrector, using the tip technique, that is a 2-incision push-pull technique, or using the femtosecond laser, plasma blade, or precision pulse capsulotomy, or the Zepto. And we should always stain with the trypan blue dye, that is 0.06%, which decreases the elasticity of the anterior capsule. The anterior CCC should be around 5 mm, and the posterior CCC should be around 4 mm. Tips are, we should pull the capsular rhexis centrally. We should use a cohesive viscoelastic, and we should take frequent bites of the anterior capsule. So cohesive viscoelastic, it flattens the anterior capsule, keeps the anterior capsule taut, and counters the effects of low scleral rigidity and vitreous upthrust. Then multi-quadrant hydrodissection should be done using a cannula mounted on a 2 cc disposable syringe, and at least 3 quadrants should be done. Coaxial or bimanual lens matter aspiration can be done. Start from the periphery and swipe clean. For the IOL implantation, the anterior chamber is filled with high viscosity viscoelastic, and push the leading haptic underneath the anterior capsule, then push the trailing haptic into the bag using a Sinskey hook. A single piece hydrophobic acrylic IOL is preferred for in the bag placement. There is less PCO in such IOLs, as well as less pigmentary deposits. 3-piece can also be used in case of an inadvertent PCR. Monofocal IOLs are preferred in children. Multifocal can be used in children more than 5 years of age with bilateral cataracts. The lens IOL material, if it is a silicone lens material, then it can lead to calcification with asteroid. A hydrophilic can opacify early. So the hydrophobic acrylic is the most favorable. The PMMA is very good if there is a big PCR and it is stable in the sulcus. But for that we need to increase the incision. Peripheral iridectomies should be done in patients with aphakia who are left aphakic, or uveitic cataracts, as they prevent the formation of iris bombae, or any traumatic cataracts. It can be done with a vitrector, and if there is a bleeding, we should give air tamponade or viscoelastic tamponade. Then primary posterior capsulotomy and anterior vitrectomy can be done, as PCO is the most frequent complication. So we do it in the cut IA mode of the cutter, and if we don't do it, then it leads to 100% PCO rate in children. So this is done in children under 8 years of age, but vitrectomy, capsulotomy and vitrectomy is done up till 6 years, and we do just a PCC till 8 years of age, or in children who are mentally retarded or cannot cooperate for a NDA capsulotomy later on. So suturing must be done. It can be done with a 10-0 nylon suture or a vicryl suture. Vicryl is absorbable. So why suturing is done in children less than 2 years preferably? Because they have a low scleral rigidity, increased elasticity, and more vitreous upthrust. This leads to AC shallowing. and increases chances of end off later on if we don't suture the wounds. Also, we should give preservative-free moxifloxacin intracamerally and subconjunctival dexamethasone. We can also give intracameral dexamethasone or Canacort. Post-operatively, topical corticosteroids should be given 6 to 8 times a day, tapered in 4 to 6 weeks, and topical antibiotics 4 times a day. Topical cycloplegics like cyclogel or homide for 2 weeks, preferably homide. And follow-up period, we should use glasses or contact lens and patching for amblyopia. So these are some videos which I'll show. Music. So after making the side ports, we stain the anterior capsule with 0.06% trypan blue dye and wash it off. We fill with the viscoelastic, that is a cohesive viscoelastic is preferred. We use the cystitome to start the incision, and then we complete it with the Utrata forceps. We do a multi-quadrant hydrodissection, at least 3 quadrants should be done, and then we do bimanual irrigation aspiration. We should always polish the bag and the capsule because PCO rates are very high in children. Then we enlarge the incision and put the IOL. So this patient didn't have a PCN, but we still put a 3-piece IOL because the patient was not affording. And after putting the IOL, we do a vitrectomy and a posterior capsulotomy and fill the chamber with air after suturing. This is the use of intracameral mydriatics in pediatric cataract surgery. After staining and washing of the trypan blue dye, we put phenocaine. You can see how beautifully it dilates. Have to re-grasp the anterior capsule again and again. And you'll see how beautifully the nucleus parted comes up. This is another video in which we used triamcinolone intracamerally to prevent post-operative inflammation. This was a single piece which was implanted. Then we did capsulotomy and anterior vitrectomy, and then after hydrating we put a wee bit of triamcinolone and washed it off, and then put the air bubble. This was another video in which there was a calcified anterior capsule, so we used the vitreous cutter to cut the anterior capsule. We were unable to use the cystitome for making an opening, so we used the vitrector in the cut IA mode. So this was an almost absorbed cataract with calcification. We did a PI in this because the patient had microcornea, so any eye is less than 10 millimeter white to white, and a less than 17 mm axial length we leave a phakic, so that's why we did a PI. So summary, congenital cataract is an important treatable cause of childhood blindness, and it should be managed promptly to achieve good visual acuity. In the bag placement along with primary posterior capsulotomy and anterior vitrectomy is essential in the younger age group, and post-operative care and follow-up are inevitable to achieve an optimal outcome. Thank you so much.
Thank you, Dr. Parul. Thank you, Dr. Parul, for your excellent presentation. You have shown very nice videos. You told in one of the slides that you use mediatic intracameral. Which mediatic you use?
So we can use intracameral epitrate, or that is ADR, adrenaline, but ideally it should be preservative free, or we can use phenocaine. So they have a combination of tropicamide, phenylephrine hydrochloride and lidocaine hydrochloride. So that beautifully it maintains the dilatation of the pupil and causes the dilatation of the pupil is very small, and it maintains it also and provides anesthesia also.
Madam, do you dilute it independently?
No, we don't dilute. We just put just 4 units, 0.05 millimeter,
Syringe or
1 cc.
you use syringe or you use more final syringe like
30 kg, yeah, insulin one, yeah.
Another thing is that in the post-operative period, surely I think beside frequent topical steroid, we use cycloplegic agent.
Yes, sir.
And we have seen several parents, they may not use cycloplegic agent.
Yes.
And people will be 360 degree, Syniki will be there, 360 degree. So I think we have to take care of
Take
that
care of
point.
that, yes.
Usually we consider that okay, there is no inflammation,
Yes.
but I think that once I think inflammation is there, that adherence and annular Syniki will be there.
And will be there. Yes,
People
sir.
will be totally close. In several cases,
Several cases.
we have to do synechiotomy and
Synec-
again
and
resurgery.
membranectomy. Yes, sir. Yes, sir.
Any question from the audience?
in such case can we advise atropine drops on table or
Atropine drops are usually avoided in children actually, because they lead to hypothermia.
Usually, we do whatever dilatation we achieve it before starting the surgery. That is our first aim, and we have not used during surgery or at the end of the surgery. We have not used atropine.
my intention was to prevent synec.
No, you are right. You are right, but
There is a synec here, atropine vision will be clear.
Yes.
So I think hometropine is a better option if you want to put at the end of the surgery. But usually you have a dilated pupil with a cycloplegic which you've used pre-operatively, plus you use intracameral mediatrix as well. So on the first post-op day, usually the pupil is dilated unless you use pilocarpine for doing a PI or something. So probably it works well, and then you start steroids and you start hometropine the first day only. So the first post-op day you start hometropine as well.
I think pilocarpine should be avoided in these children, particularly in children. But homide is fine, that is all right. Because that will dilate only mid-dilate, that will a bit mobilize the people.
And every case you go for PVI.
Primary
PI.
posterior capsulotomy.
PVI.
PIs.
No.
There are certain cases, like if we are leaving the patient a phakic, so in order to prevent pupil block glaucoma, we do that. Or in case the patient is has history of uveitis, then the posterior synec will form on the IOL. So to prevent the aqueous from not coming, so we make a PI.
Every time we have to subject them for minor thing, what until the
Yes.
we can do prophylactic PI.
It is not recommended
Not
in all
required in
children.
Not in
cases.
pseudophakics. Not in pseudophakics.
I
The phakic,
think
yes, you
in
have to
certain
go.
situation, if it is a case of JIA, case of uveitis, and we know people is small, selectively we do peripheral iodectomy. But not once we place IOL, dilatation is good, place IOL in the bag, then we don't do